Hi everyone, welcome back to this year's Bite-Size Series 2026. This year's series is going to be focusing on liver lesions. Last year's series was on medical liver biopsies. It will be composed of 6 sessions which will run until November this year. For those of you who have attended previously, welcome back. And for those of you who haven't, there's a link to the recordings from last year's series in the chat, which you can have a look at. Next month's session after this one will be on the 4th of March with Paul Kane talking about hepatocellular carcinomas and mimics. And there's also a link to the registration in the chat as well. Well, without further ado, I'd like to now introduce Sarah Al-Jujali, who will be the chair for this session. Thank you, Sarah.
Thank you, Ali. Good afternoon, everyone. Thank you for joining us on this webinar today. This is part of the Liver Pathology Bite-Size Webinar Series. Today's topic is benign hepatocellular lesions. The webinar will take about 1 hour and it will include approximately 45 minutes of presentation. Then it will be followed by a short Q&A session. So if you have any questions, please use the Q&A function at the bottom of the screen. Please note this webinar will be recorded and attendees can self-accredit 1 CBT point for attending today's webinar. Now I'd like to introduce our speaker today, Dr. Rachel Brown, who reports liver biopsies, including medical and transplant ones at Birmingham, Queen Elizabeth and Children's Hospitals, along with HBB Oncology. She is the outgoing chair of the UK LBG and one of the organisers of the UK Liver EQA. Over to you, Rachel. Thank you.
Thank you so much, Sarah, and thank you to Ali and Alan who organised these bite-sized webinar series. I feel really honoured to be invited to speak today. So here is my topic, benign hepatocellular lesions. Let's launch into that. So what I'm proposing to do this lunchtime, I'm going to speak to you in a very practical way about how I approach these lesions. I'm going to finish with the 3 cases that have been shared in advance of the meeting today. And I'm going to use a couple of other cases that I've seen in referral practice, quite tricky ones, to illustrate some of the difficulties that one can run into with this area of pathology. So what are we speaking about today? Benign hepatocellular mass forming. I've included that phrase in there because sometimes when we talk about lesions, of course, it's a very generic word, but what we're focusing on today is those mass forming lesions. And to begin with, we can sometimes see tumor-like lesions. So mass lesions which are not neoplastic. And the archetypal example here would be focal nodular hyperplasia, FNH. FNH is an easy diagnosis if you think of it. But if you've just got a biopsy specimen and it's something that looks like cirrhosis, but on the request form it says they've sent this as a targeted lesion, a targeted biopsy from a mass forming lesion and nothing is making sense, until the penny drops that you might be looking at an FNH, that's what makes it difficult. Once you've thought of it, it's relatively straightforward. It has very well described features of fibrous septa, biliary ductules. If you've got the whole lesion, you might see a central scar within it. So FNH, we'll be speaking about that a little bit later. Easy if you think of it. And just a note for residents out there in particular, something that I find when I'm teaching causes a lot of confusion is focal nodular hyperplasia as a discrete mass forming lesion. It can occasionally be multiple, but as a mass forming lesion is not the same. It is distinct from nodular regenerative hyperplasia, NRH, which is usually a diffuse lesion in the liver, which can cause some nodularity as its name implies, but it's a diffuse lesion. It's not a discrete mass forming lesion. So just be careful with your nomenclature in this area. So tumor-like lesions, and then lesions that we regard as being potentially at least pre-neoplastic in the liver, and those would be hepatocellular adenoma, and then in a dysplastic or regenerative nodule. And as I've just put in bold there, the really defining features here is this background liver, the context in which that lesion is arising. Is it a mass forming lesion that's arising in a cirrhotic background, or a mass-forming lesion that's arising in a non-cirrhotic background. This is absolutely critical to your interpretation. And it may, ideally, you're in a situation where you have sight of the background liver as well as the mass-forming lesion, but sometimes you might just all have lesional tissue in your biopsy, and so you need some clinical history, of course, like always. But it's absolutely crucial to know what background your lesion is arising in. And of course, these lesions need to be distinguished from hepatocellular carcinoma that's going to be dealt with in the next bite-sized session, but I'm just going to say a word or two about that today, distinguishing benign from malignant lesions, because of course it's something that any of you who've experienced it will know is a day-to-day challenge in our diagnostic practice. So what sort of questions go through your mind when you are confronted with these type of specimens? So first, often we can really struggle to know whether or not we're looking at a lesion in the liver. It's particularly a problem in biopsies, but it can also be difficult in resection specimens. So I'm going to spend a bit of time talking to you about that. Another decision that you have to make is, am I looking at something that's genuinely hepatocellular? So this is important. There are mimics. Neuroendocrine tumors would be a common one in practice. So we must ask ourselves that question. That isn't the same as having to do a lot of extra stains to come to that conclusion. If you're looking at something that's made up of hepatoid cells that are making bile, or there's lots of fat, for example, you can feel pretty comfortable that you are looking at a hepatocellular lesion. So need to ask yourself that question. You don't necessarily need to do more stains in that regard. Then, of course, you have to ask yourself, is it benign or malignant? And then you're going to think about your differential diagnosis. And as I've just mentioned, that is going to depend on the context in which this mass lesion is arising. And if your conclusion is that you're looking at a benign hepatocellular lesion, can you subtype it? So the cases I'm going to show you today hopefully will help you in resolving these questions. I'm going to begin then with a case. So this is a case that I saw in practice that was really difficult. So a 33-year-old female and has a family history of hemochromatosis. This is what was on the request form. They have a mass-forming liver lesion that has been described as looking malignant on the MRI scan. And this is a case that was reported elsewhere and came to us here in Birmingham in consultation. The team had done simultaneously a biopsy of the background liver. This is great from our point of view. So we know the status of the background liver. And in this case, background liver looked normal on H&E sections. There was actually a faint blush of iron present, but a non-cirrhotic background. So the image that you're seeing here is from the lesion, the biopsy that was labeled lesion. And this one, we know then it's potentially a lesion arising in a non-cirrhotic background. And it looks hepatocellular at low power, and it's got some structures within it. We can already see that some of the sinusoids look a little bit dilated. Looking at higher power then, clearly looks hepatocellular, doesn't it? The arrangement of the cells, we can't see a great deal of the cytology at this power, but it looks like liver tissue. And there are structures within it as well. So let's have a look at those in a little more detail. So we've got something here that includes fibrous tissue. There's an artery here. And there is some biliary epithelium. So that's present around the periphery of this structure, so maybe ductules. What we look for in a portal tract would be the pairing of an artery and bile duct. And the duct itself would be close to and a similar size to the artery and usually quite rounded. There may be a duct there. It's hard to say for certain. So we need to be asking ourselves the question, are these truly portal tracts? Is that the kind of appearance we would usually expect in a portal tract? Elsewhere in the biopsy, this kind of appearance, so at higher power now, this dilatation of the sinusoids, and there's a little bit of vascular congestion. But the other thing you can see, it's fairly subtle, but once you've got your eye in, you'll recognize it, is this type of structure. This is an unaccompanied artery. There are a few other things catching the eye, hard to know exactly what they are, but an unaccompanied artery here. And then what about these structures? We've got structures that are a little bit close together. That might be one observation we would begin with. And then these two, hard to know what these are. Could we be clipping the edges of a portal tract? And what about this one? This does have an artery and what looks like a paired bile duct, but there isn't very much connective tissue there. It isn't perhaps entirely typical of what we usually expect in a portal tract. But this one, which has been longitudinally sampled, has got an artery down the center and then a couple of bile duct profiles here. This one, I would suggest, has an appearance much more typical of a normal portal tract. So now we're thinking maybe we have got some background liver in with this biopsy that was labeled lesion. And then another of these structures. So this one, it's got ductules around the periphery. It's got really quite a large artery here. There's another arterial profile there. And although there is a biliary structure here, it isn't quite right to be a duct proper. It certainly isn't of the similar caliber to that arterial profile there. So ask yourself, is that a true portal tract or not? And then what about this one? There's maybe a tiny bit of biliary epithelium there, but there's an artery that, for all other intents and purposes, does feel rather unaccompanied. So just take a moment to think here, what would you do next? And what questions of those that I presented you with at the start, what is going through your mind now with this biopsy? So young woman, we know the background's non-cirrhotic. This biopsy has been sent as being from a mass-forming lesion. What are those questions? So I would propose that in this case, I don't think there's any need to prove that we're looking at a hepatocellular tissue here. So we don't need to use the tissue in this instance with any of these stains that one might use to try and confirm hepatocellular origin. I think we'd all be confident that this is hepatocellular tissue. I think the really difficult question in this case is it lesional or not? This is the hard question to answer here. So in terms of what else you might do, the kind of additional stains that might go through your mind to perform, reticulin, super useful in the discrimination of benign from malignant. Really, there aren't features concerning for malignancy, I wouldn't say, in this particular case, so it's very unlikely to be deficient. It may have utility lower down, I'm going to discuss in a minute, but other things, Ki67, this is going to have a low proliferation fraction, isn't it? I don't think that's really going to help us. You might think about doing a CD34, but really, I don't think we've got malignancy in the differential diagnosis. Having said that, some stains that one might use in that scenario can occasionally be of utility rather than subtyping necessarily your lesion. Sometimes they help you to identify a lesion. So they help you to answer this question. And in that category, I would have the reticulin. Sometimes it won't be deficient, but it might have a subtly different pattern in the lesional as compared to non-lesional areas. CD34, I'm going to show you in a minute, can help you sometimes to delineate a lesion, let alone classify it. And likewise, glutamine synthetase can help you with that. In this case, if it is lesional, what's our differential diagnosis? I would feel from these H&E appearances, I'm thinking more about adenoma. Might you consider FNH? There are some ductules there. There are not really very big fibrous septa, but you might have that as a differential diagnosis. So this then is the panel of immunohistochemistry that I would use in this case, a liver fatty acid binding protein, C-reactive protein, serum amyloid A, beta-catenin, and a glutamine synthetase I would include here as well. So that would be my approach in this case. It had already had some staining at the external institution, and a CD34 had been done. And I think this shows you, in this core, we're looking at background liver here. So the CD34 stains endothelium in periportal regions in the normal liver, but not beyond that. So rather unusually, really, that because of the specialized nature of hepatic endothelium, it doesn't stain with CD34 beyond this periportal region. So that's the kind of pattern one would expect in normal liver. Whereas in this core, it's clearly different, isn't it? I would suggest it's not entirely diffuse, the staining is still patchy, but what it has given you is an insight into the fact that there is some hepatocellular tissue that's different in this biopsy and could be lesional. The stain that absolutely gives it away in this case is CRP, serum amyloid A, might have a similar appearance. And what this immunohistochemical stain is doing is highlighting lesional areas. There's a little bit of lesion on the end of that core. These are positive, and importantly, the background liver is negative. So interpretation of these two stains, CRP and serum amyloid A, requires you to show positivity in the lesion and negativity in the background. If you've got positivity at both locations, it isn't really going to help you. You can't rely on it. But in this scenario, it's very cleanly positive in those lesional areas and negative in the background. So I would put it to you that there is lesional sampling in this case, and I would be prepared to offer a diagnosis of inflammatory hepatocellular adenoma. So it's really the presence or absence of true portal tracts. Okay, so true portal tracts with paired arteries and bile ducts. They look like the portal tracts you recognize from looking at liver biopsies. This is the key thing to differentiating lesional from non-lesional tissue in benign hepatocellular lesions. I'm not saying it's always easy. Some of those, I think this is a really difficult case that I just showed you, and I'm not surprised that the initial impression was that there wasn't a lesion present. It isn't always easy. And you will sometimes see some biliary structures, and whether or not you're looking at the duct itself or a ductule can be very difficult. So looking for those unaccompanied arteries, asking yourself the question, am I seeing portal tracts or not? That's absolutely central. The parenchymal architecture can sometimes help you. So in this particular case, I've just shown you the sinusoids were a little bit dilated, and in fact, the hepatocytes had a very subtly different appearance in lesional to non-lesional areas. They might be slightly larger, they might be a bit smaller and crowded, but there might be some subtle differences that you can appreciate, and that reticulin can sometimes help with that. We need to know about the background liver. We had a biopsy of it in this case, but if you don't have a biopsy, you need to be consulting the patient record to find out if they've got a history of cirrhosis. Both so for the setting in which the lesion is arising, but also, as I showed you with the CRP and amyloid A, you need the background to interpret that immunohistochemistry. And as I mentioned, sometimes additional stains can help you in this answering that question, have I got lesional sampling or not? Of course, you're going to take every case on its individual merits, and you're going to make judgments about how much tissue that you've got. So think carefully before you're asking for those additional stains, and don't waste tissue doing hepatocellular markers when you're clearly looking at something that's obviously hepatocellular. This is the WHO classification of hepatocellular adenoma. So HNF1 alpha inactivated, inflammatory hepatocellular adenoma, and adenomas that include mutations affecting the beta-catenin pathway. I've just highlighted the section here that deals with histological features because it's nice and concise. So the example we were just looking at, an inflammatory hepatocellular adenoma, the sinusoidal dilatation is there that we just saw, congestion. You can see some inflammation, although despite the name, it often is not a prominent feature. You can see ductules. And the term that they use here is pseudoportal tracts. So that's quite a nice term, actually. And I think several of those examples I just showed you would, pseudoportal tract is mimicking a portal tract, but it isn't quite right. And it doesn't have a duct next to the artery. You can see steatosis, you can see fibrosis, and you can see some nodularity of architecture. So that would be the features of typical features for an inflammatory hepatocellular adenoma. Other two major types of adenoma are described here. So the HNF1 alpha inactivated, typically a steatotic lesion, can be multifocal. More on this coming later. And then the beta-catenin pathway mutations here. And you'll note here they refer to some cytoarchitectural features of pseudoglands. So I'm just going to illustrate that for you just in case that it isn't clear what exactly that means, and also the reticulin. So leading directly on from that, if you are looking at tissue that you are convinced is lesional, you're convinced it's hepatocellular, but you're worried, am I looking at something benign or malignant? So these architectural features, the pseudoglands I'm going to illustrate in a moment, the reticulin is super important. CD34 can sometimes help you. As I illustrated before, in lesions, you can get more extensive expression in the sinusoidal endothelium with CD34. It's referred to sometimes like this, the capillarization of the sinusoids. And Ki67, we've started including that in our panel relatively recently, and it's not always helpful, but just occasionally it has been in asking yourself that question, am I in lesion and is it benign malignant? We do include that now in our panel if we've got enough tissue. So I'm sharing another case with you here just to illustrate a couple of those points. 68-year-old male, this is another one that came in consultation, referred to our MDT. And it came with this history on the original request form: cirrhosis and increasing liver nodule query HCC. I managed to find a little bit of extra information. So the patient did have risk factors for chronic liver disease, and it seemed like quite a good clinical history of cirrhosis. They've been treated previously for an HCC elsewhere in the liver. This is a new lesion that's enlarging that's now been biopsied. So we're thinking now in a slightly different way, aren't we? Because this patient's got cirrhosis. So by definition, they haven't, even before we pick the slide up or look at it on the screen, it's not an adenoma, is it? Because they got cirrhosis. This is what the biopsy looked like. Pretty good cause. And you'll notice someone's put a mark at the bottom of the screen there. We're going to see that little fragment again in a minute. Most of it looks like this. Clearly hepatocellular, I feel. Lots of, not lots, but there is some steatosis in some of these cells. You also got some of these structures that look a little bit like those pseudo portal tracts we were just speaking about, and things that look like central veins. So we're even at a point in this biopsy of wondering, am I looking at lesion or not? We've been told that patients got cirrhosis. It doesn't obviously look cirrhotic in what we've got here. And I think that's because, in fact, the majority of this tissue was lesional. There's only a tiny bit of background liver. So I would suggest that this is background liver here. It's very hard to know, but we might be looking at a cirrhotic nodule there. We can't say for certain. I think we've got some lesion here. And the rest of the tissue is lesional. And even at this power, do you start to get the feeling that there is less reticulin here? So at higher power, I've tried to include a region where we've got a more normal reticulin pattern, where the reticulin is present either side of the hepatocyte plate, just to make the point that when you have got steatosis, it is going to distort your reticulin architecture. But even allowing for that in this field, I hope it will be clear to all of us that there is deficiency of the reticulin here. So this is what we mean by reticulin deficiency. That's what you're looking for in your lesion. So this is how I concluded this particular case. So a well-differentiated hepatocellular lesion. We haven't got enough histologically to confirm cirrhosis, but we're told that that's the situation clinically. So we know already, without looking at the case, that our differential diagnosis really is going to be between a large regenerative or dysplastic nodule. I don't use that term, I must admit, in my own clinical practice, but a large nodule in cirrhosis or a well-differentiated hepatocellular carcinoma. It's incredibly well-differentiated, isn't it? And out of context, you could look at that tissue, I think, and be forgiven for thinking about an adenoma, but it clearly isn't, because the patient's got cirrhosis, and we're pretty confident about that in the broader clinical scenario. But the reticulin deficiency, I feel in this case, is convincing. There was also an elevated proliferation fraction slightly, which I didn't show you. And so my conclusion was, I think this is a well-differentiated hepatocellular carcinoma, and based predominantly on that reticulin loss. So again, tricky case just to illustrate how difficult it can sometimes be, but how important the context is when you're looking at well-differentiated hepatocellular lesions and you've got a benign lesion in your differential diagnosis. So just to illustrate, unless it isn't clear to anyone, what's meant by the WHO calls these pseudoglands. I tend to use the phrase asana structures, but with both of those, the importance is these are not ducts, are they? They're not true ducts like you would see in adenocarcinoma. That's a really important distinction. These cells are clearly hepatoid, and I would suggest clearly hepatocellular because they're making bile. We've got bile in this section. You could, even without these structures, that there's abnormality of the architecture. Just in the H&E, we get an impression of how thick these trabeculae are. But it's doing this. It's forming these asana structures. And you would notice in that WHO classification, it does mention that in the HNF1 alpha inactivated adenomas and in the beta-catenin pathway abnormality adenomas, you can see a couple of these in an adenoma. But if it's a lot like this, you start to worry that you're looking at something malignant, and you would be wanting to address that question probably with additional stains. So just so that you are clear what is meant by that term, pseudoglands, that's what you're looking for as an architectural feature in your lesion. Okay, so that's it with my introduction. I'm going to press on now with the 3 cases that hopefully many of you will have had a chance to have a look at before the session today. So they come from our National Liver EQA, which has been my privilege to be involved with in the last few years. And I still learn a lot from it. And I think from a teaching point of view, I think it helps us to identify areas of liver pathology that we as a community struggle with. And benign hepatocellular lesions is one of them that we're talking about today. So this first case was sent as colorectal liver metastasis, quite a common clinical scenario. In many departments, we receive liver resections in great quantity here in Birmingham for this indication. So that's what was written on the request form. It was a 44-gram resection from segment 3 and a 9mm lesion in it that was noted at gross assessment to be yellow, and it's in a 53-year-old female. And these 2 slides were available for viewing. So let's have a look at it at low power first of all. So it's a resection specimen, so we've got plenty to look at. So we've got background liver here, and then this pale region, which I hope we can all appreciate, as a mass-forming lesion in this section of liver. And this would correspond to that yellow lesion that was visible grossly. So first things first, what context is this mass-forming lesion arising in? Is it a cirrhotic background or a non-cirrhotic background? So let's have a look at the background liver here. And what we can see here is some true portal tracts. This is a nice contrast to what we were just looking at with paired arteries and bile ducts. Another one here, artery bile duct. And also the spatial relationships here. So the spatial relationships between portal tract and portal tract and central vein and another portal tract look fairly even, don't they? There's preservation of vascular relationships, tiny bit of fat here. So this is a lesion that is arising in a non-cirrhotic background, super important for your differential diagnosis. Let's have a look then at the lesion itself. So in that low power image, I think you could appreciate that there's some paler areas and some more eosinophilic areas. So we've got we are within that mass forming area here in this section, but we've got a paler area and more eosinophilic area. And it's tricky because in this region, I mentioned to you the unaccompanied arteries, and once you have your eye in for them, there are loads actually in this section. So I'm just pointing out a few here. There's another one here. So unaccompanied arteries. But then we have got this structure, which, I think we can't argue is very portal tract-like, let alone pseudo-portal tract. So we've got a mixture of unaccompanied arteries and structures where we can't be 100% certain if that is portal or not. And then the other thing in terms of the cells themselves, more eosinophilic, paler. Why are they pale? Because of steatosis. I've got a higher power again in a minute. Just another couple of these troublesome structures. Is that true portal tract or pseudo portal tract? I can't be 100% certain, but that for sure is an unaccompanied artery. There's another one there. So I do think that I'm in a lesion here. Here's a higher power of that steatosis. So if the steatosis is tiny droplets that impart a foamy appearance to the hepatocytes, we would refer to that as being truly microvesicular. And in actual fact, in diagnostic practice, it's very rare to see that lesion, and you usually see it in the context of metabolic liver diseases. So I tend to restrict my use of that term to that scenario. This, I'm pretty sure I would describe as small droplet macrovesicular steatosis. Some of the fat droplets are slightly bigger, but they quite clearly are fat droplets. So we've recognized that this is a steatosis, and that's what's giving rise to the pallor and presumably the yellow color grossly. This is the liver fatty acid binding protein immunohistochemistry, and it's positive in the background liver, and it is lost from the lesion. So here's a higher power of that, background liver here, and lesion at the bottom. So that was the case. So have a think about how, hopefully you've already had a chance to do this. What's your differential diagnosis here? And what else would you like to know? Would you have just done that stain yourself, or would you have done other things? Obviously, the EQA is not real life, but it is a pointer towards it. So you don't get offered everything that one might have done in practice. And we were given some additional information here that the glutamine synthetase did not have a map-like pattern. Don't worry if you don't understand that. We're going to come back to this concept. We talked about these stains in the setting of inflammatory hepatocellular adenoma. They were negative here. There was no nuclear expression of beta-catenin. So there's some extra information for you. And the diagnosis here was offered as HNF1 alpha inactivated hepatocellular adenoma. And in terms of the EQA, that achieved really good consensus, actually. So despite the fact that, if strictly speaking, it was hard to identify necessarily all the classical features of a benign hepatocellular lesion and adenoma in this case because of those structures that looked a bit like portal tracts. The majority of responders felt comfortable. They were looking at a genuine lesion here and offered this diagnosis. And the EQA did decide there was a consensus of responders commenting on the background liver, and in fact that did get included as a criterion on which to score the EQA. And we felt at the time when we all discussed this, it's so critical to know the status of the background liver in order to guide your differential diagnosis for benign hepatocellular lesions, that was important to use in scoring. This was my case that I submitted to the EQA, and this is our follow-up information. It was a super interesting case, I thought. So this patient is from 2024. This was one of 2 non-anatomical resections, and there were similar lesions in both. And they'd actually had a previous resection 2 years prior, which my colleague had seen and had to work hard for because they sent several frozen sections, lots of different resections, and some of them were colorectal mets, but there was also a selection of alternative diagnosis. I think this is very interesting, actually, because all of these, well, certainly these 2, but probably this as well, can be related to abnormal vascularity in the liver. But this patient had a variety of benign lesions. She also unfortunately had a lung metastasis, but remains well at the last time that I checked the record. So that was case number 1. Case number 2. So here's the history for this case. An incidental lesion, segment 4B of the liver, so a patient being investigated for another disease, kidney stones in this case, and initially thought to be FNH, but might be adenoma. So FNH, remember, focal nodular hyperplasia as a mass-forming lesion, and it's biopsied. Female patient, young, 39, and there was some more information that I'm withholding just for now. Here are the cores, really generous sampling. Just looking at it at low power here, we're starting to get the impression there is some dilatation of the sinusoids here, maybe a little bit more down here, but nothing else really leaping out at low power. It looks like hepatocellular tissue. And then a medium power, here's a structure that looks like a central vein. Some kind of structure here. Is it a true portal tract or is it a pseudo portal tract? Dilated sinusoids. So have a look at these three structures. So remember what we're potentially looking for here. Are we looking at true portal tracts or pseudo portal tracts? And certainly this one down at the bottom right-hand side, it's got some foamy macrophages in it, but there's an artery here that looks unaccompanied, doesn't it? So that starts to raise our index of suspicion. This one has an artery coursing north to south across it, longitudinally sampled. There are a few inflammatory cells here in this structure, not obviously any biliary epithelium. And then this one, again, a prominent artery without an obvious duct. A few more of those foamy macrophages. So just have a think about what you think those are. So we've got a mass lesion biopsy. It's clearly hepatocellular, I think. I wouldn't be spending time trying to prove I was looking at a hepatocellular lesion here. Is it lesional? If it is lesional, is it benign or malignant? So just have a think about what you would do next, what you would want to know. I think we just had an H&E in this case to look at, so you would want to be thinking about the way in which you would work at this case, and having a favoured diagnosis, particularly if you're preparing for an exam, have a favoured diagnosis. Here's that extra information then. Diffuse immunopositivity for serum amyloid A and for glutamine synthetase in this case. Although no non-lesional tissue for comparison. So that relates to this point that I was making, that in order to interpret this stain and also the CRP, the same applies. You really want to be seeing positivity in your lesion and negativity in your background liver. In this case, in contrast to the last one, the liver fatty acid binding protein is retained. There is quite widespread, we're told, expression of CD34 in sinusoidal endothelium, no nuclear beta-catenin. So there's some additional information for you. So just have a think about what diagnosis you'd be prepared to offer here. So this was submitted as an example of inflammatory liver cell adenoma, inflammatory hepatocellular adenoma. I showed you an example at the beginning, so hopefully that had some echoes here. In terms of how the EQA members responded to this case, there was a consensus of people who recognized this as an adenoma, but not a consensus in terms of the subtyping. So that's that case. Case number 3. So this is our final case for this session. We're doing fine for time. So written on the request form from this one, query HCC, a segment 2/3, non-anatomical resection. That's all that was on the form. I went back and looked at the patient record, and this is an incidental finding in a patient with known congenital heart disease. And in this case, to look at was a section of the lesion and a section of the background liver. It's a young woman. So a small liver wedge, 20 millimeter subcapsular lesion, well clear of the margin. It was noticed at the trimming bench that the background liver had a slightly diffusely nodular appearance. but it was vague, so not typical of cirrhosis. So here is the section that has the lesion in it. So we're expecting it in a subcapsular location from that description, and indeed here it is. So reasonably well delineated immediately beneath the capsule. We've got some background in this section as well. There's a separate section of the background liver, of course, but here is the lesion. Looks at this power like it's going to be hepatocellular, but we'll want to look a little bit more closely. The other thing that we can see at low power, there are some fibrous septa within it. There isn't obviously a central scar, I would say here, that is really appreciated, but there are some fibrous septa. Here we are more medium power, so the background liver is here on this side, and here we've got the edge of the lesion, which you can see it's fairly, becomes harder to define the higher power you go, which is quite often the scenario here. It's useful to keep coming back out to low power to define where you think that a lesion is. And here's an example of a fibrous septum. And higher power still in these fibrous areas, really quite prominent vessels. These look like arteries, and some of them look a little thick-walled. There's more examples up here. A little bit of inflammation, not a brilliant image, but we're starting to appreciate there are some biliary ductules here, but not really any true bile ducts, I would suggest, in that field. Slightly higher power again of these structures. So here's arterial branches, quite thick-walled, not obviously accompanied by bile ducts, and biliary ductules, more obvious here at this power. Biliary ductules again in this structure, which has arteries in it, but no obvious bile duct. So this is the glutamine synthetase stain, and I think it's a nice example of map-like staining. So that means just exactly as it would suggest, that you potentially, it's like looking at continents on a map, if I can convince you of that. So map-like staining with glutamine synthetase, as opposed to the background liver where you get staining around the central vein. So that's what you see in the background liver. And when I was mentioning earlier that it can be a stain that can be useful to confirm the presence or absence of a lesion, it's really obvious in this case, but if your architecture is disturbed and you lost this perivenular staining, that can sometimes be a clue. I think, yeah, I took that at higher power. So you can see in the background here are portal tracts. We're in the background liver here, and this perivenular staining, which is what you expect in background liver. So glutamine synthetase, so FNH has this characteristic pattern. So there's activation of the beta-catenin pathway, but not a mutation. As I've said at the beginning, these are lesions that are not regarded as being neoplastic in nature. So this is an example of focal nodular hyperplasia. I've given the game away slightly early there, but hopefully you were able to reach that conclusion. So a glutamine synthetase was provided. I withheld this information from you just now, but it was there when the case appeared in the EQA. There's a preserved reticulin, there's no nuclear beta-catenin, negative staining with these stains that we use for inflammatory hepatocellular adenoma, and there was a low proliferation fraction. So let's just take a moment then with the background liver here, and there was a collagen and reticulin stain provided. So here it is. Not much to comment on at very low power, except to say it doesn't look cirrhotic. So this is a lesion that has arisen in a non-cirrhotic liver. Here's that HVG stain. So we're thinking about vascular relationships again here, maybe some small portal tracts a little bit close together there, a couple of central vein profiles look a little bit close. And even at low power, there's a bit of a blush of staining there. And when you look at higher power, that's because there is perisinusoidal fibrosis here. And then on the reticulin, that perisinusoidal fibrosis corresponds to a region of hepatocyte plate atrophy. So there's a nodule here. It isn't surrounded by fibrous tissue, it's surrounded by atrophic cell plates. Here's the same thing at lower power. Here's the atrophy. Look how thin the plates are compared to these in the middle. and another region here with more normal appearing plate thickness, but with regions of atrophy around the periphery. So I'm sorry, I gave that away. So the lesion is focal nodular hyperplasia. And what background is it arising in? So we had this extra bit of history, didn't we? That this was an incidental finding in a young patient with known congenital heart disease. So what should the MDT have thought about before this lesion was removed, really, is the question. So there's a chronic vascular pattern of injury in the background over here that one can see in patients with congenital heart disease. And in any of those any conditions affecting vascularity in the liver can be associated with the development of certain lesions, particularly FNH. So it should have gone through our minds and really before the patient had surgery. That this could be an FNH because we could have predicted that this individual would have had the vascular features. The EQA responders, really strong consensus for recognizing an FNH here. And I think it is an important lesion for any of you out there who are coming up to an exam to be familiar with. So you've seen a nice example now of focal nodular hyperplasia. And unfortunately, there wasn't a consensus amongst the responders for a vascular pattern of injury in the background liver, but I think that it makes quite a nice story in that particular case. So I come to the end now then. So hopefully I have introduced you at least to the idea of how to identify lesional sampling in benign hepatocellular MASH lesions, which can be a diagnostic challenge. And if you are looking at a benign hepatocellular mass-forming lesion, how you might go about attempting to subclassify those. So I'm going to finish there and I am happy to take any questions.
Thank you so much, Rachel. That was an excellent presentation. So we do have some questions. So the first question is, do you consider the absence and the presence of portal veins when assessing unpaired arteries and portal tracts or not?
Of portal veins?
Yes.
Yes, yeah, I do. So in these so-called pseudo portal tracts, you're quite often missing a vein as well. So yeah, it's a good point. So just as part of your global assessment, can I see the three things I'd usually expect to see in the portal tract or not? If the duct is missing, that's raising your suspicions. And yeah, quite often the vein can be missing too. Yeah, it's a great point. I do, yeah.
Thank you. Next question is, what would the CD34 used for? I think this is referred to case 1.
The CD34. So CD34, if I think it was originally described as being useful in the cirrhotic setting. So if you are confronted with a differential diagnosis, is this a regenerative nodule or a HCC developing in cirrhosis? If you did the CD34, it showed this diffuse staining of capillarization of the sinusoid. So I'm pretty sure that's where it was first used, and I think it's still of great utility in that scenario. So the first case, for example, yeah, we weren't in that scenario where it was a non-cirrhotic liver. So the CD30, I probably wouldn't have done it actually if it had come immediately through my hands. It came from outside with that stain done, but I just think it was of utility in that case just to show that the CD34 pattern of staining, it wasn't completely diffuse in the lesion. We wouldn't really expect it to be in an adenoma, but it was different from the background liver. So in that first case, I think the CD34 helped us to know we were looking at a lesion. Didn't really help us in subclassifying that lesion, but the very fact of identifying that there was lesion present in that biopsy, that's what the CD34 helped with. But I don't always do it, and I don't have a standard panel for any case actually, because you have to take each case on its individual merits. You have to make judgments about the amount of tissue that you've got present. So yeah, CD34 can be helpful. I don't always do it, but in that case it was showing us that there was lesion present.
Another question for case 1, how to differentiate the formal differentiated hepatocellular carcinoma?
So that's the case that I did in my introduction, I'm guessing, rather than case one from the EQA cases. So a reticulin is the most powerful thing there, because if you're thinking about the differential diagnosis adenoma and well-differentiated hepatocellular carcinoma, reticulin is the single most useful stain because it becomes lost in hepatocellular carcinoma. The second thing, so the reticulin, the second thing is that pseudoacinar architecture that I showed you, that is prominent in HCC. You should only see it rarely and focally in adenoma, and it wasn't present at all in the case that we had. So I didn't show you the reticulin, but it was preserved in that case. I'm pretty sure it was done. We didn't have those pseudoacinar structures. The CD34 wasn't completely diffuse, although it was different. So those are the things that, and also it does come back just to the morphology. It had those pseudoportal tracts in it, which are actually very characteristic of adenoma. So I don't mean to sound flippant, but it just didn't look, it looked like an adenoma. Once the penny has dropped that, hang on a minute, even though I'm seeing these structures that look a little bit like portal tracts, maybe they're not. Maybe they're pseudoportal tracts. Am I in an adenoma? Once you've made those leaps of thought, I think it becomes much more obvious that it is an adenoma, and it doesn't look like what you would expect to see in an HCC. So in HCC, you can see some unaccompanied arteries, but they're usually not frequent, and you don't really usually see those pseudoportal tracts. So the morphology is really important. Reticulin, so the morphology, including pseudoacinar structures, reticulin, CD34, maybe a key 67. It's not terribly useful. The H&E is the most powerful thing.
Yeah, thank you. Next question is, would reticulin not be lost in a degenerative nodule? I think they mean regenerative.
Regenerative nodule.
Yeah.
Yeah, no, it shouldn't be. But having said that, if you are in a centre where you've had an opportunity to look at explant livers, and look at a large section with cirrhosis, and there is a lot of heterogeneity in that reticulin architecture actually within the parenchymal nodules. It still remains one of the most powerful discriminators between a regenerative nodule in a cirrhotic liver and HCC is the presence or absence of reticulin. But you do have to be careful in your assessment because there will be heterogeneity in a cirrhotic liver. So yeah, regenerative nodules should have preserved reticulin, and HCCs should have deficient. Of course, there's shades of grey in clinical practice. If you're fortunate enough to be looking at a whole section of an explant liver, you have the luxury of being able to compare it to background cirrhotic nodules. If you're just looking at a biopsy, it can be super difficult. So you would try and supplement your assessment with other things. What does it look like? Is it full of those pseudoacinar structures? Now you're more worried about it. If it is, you do the CD34 in that setting, and if it's diffuse, more likely HCC. And you could do the Q67. It sometimes helps, not always, but that would be my approach to those.
Yeah. Next question is, why cannot a patient with cirrhosis have an adenoma?
Yeah. So it's a really good question, and you could say that it was sort of it's just an issue of convention, but they just can't. You wouldn't make that diagnosis. Occasionally there are people who have described both FNH-like lesions and adenoma-like lesions in the background of cirrhosis, but maybe there might be vanishingly rare examples where you could make a good case for that. But in general, in practice, if it's cirrhotic, you don't have adenoma in your differential diagnosis.
Thank you. Next question: does reticulin loss in adenomas? Can adenomas shows diffuse CD34? I think we partially answered that in the previous questions.
I think
Would
so,
you like
yes.
to add? Yeah. Okay. Thank you. Next question is, micro vs macro vesicular steatosis any prognostic significance?
Oh, yeah, that's right. And no, I don't think so. Certainly not in an adenoma. No, just it's just important to be aware that the HNF1 alpha inactivated adenomas are very steatotic typically. You can also see some steatosis in the inflammatory variants as well sometimes. But no, I'm not aware that it influences risk of malignant transformation. Not that I'm aware of, no.
Thank you. Next question is, in HNF1 alpha inactivated adenoma, do you still do other IHCs like beta-catenin and glutamine synthetase, or as long as I feel it looks clear cell with mass-forming lesion, there will be no need to do extra IHC? Thank you.
Yeah, thanks. You could argue that in that case we're only satisfying our own intellectual curiosity, really, aren't we? In that for that patient, what was important for us to say, it's not a colorectal metastasis. It looks like an adenoma. Full stop. We possibly could have ended there. So I think it's a great question. How is it necessary? I still would, and I think it's. Adenomas can be multifocal as well, and if this turned out to be a beta-catenin mutated adenoma in this patient, then maybe that has implications for their residual liver and so on. So I think it is good practice to subtype them. And yes, so if I think I'm looking at a hepatocellular adenoma, I do the whole panel. Yeah, I do.
Yeah. Thank you. Next question is, can you explain why the glutamine synthetase is MAP-like if beta-catenin mutation is not present?
Yeah, that's a great question. No, I can't really. I was reading about that this morning because it is a bit of an enigma, isn't it? That the FNH does have this activation of the beta-catenin pathway without the CTNMB1 mutations. No, that's beyond me. I'm afraid not, but it is a great question, and it's a super useful diagnostic quirk that you get the map-like pattern of staining, but I can't really explain it. No.
Thank you. Next question is, shouldn't HVG highlight fibrosis rather than cell plate thickening? I found it that confusing. Can you please explain? Thank you.
Okay, so yes, HVG does highlight collagen. So what I was just showing is that when you get plate atrophy, which your reticulin will highlight, it's often accompanied by perisinusoidal fibrosis. And I showed it to you that way around because I think atrophy is a lesion. We're not always that meticulous about looking at our reticulins, are we? I guess in practice. So you might miss the atrophy on the reticulin, but you're more likely to see that pattern of perisinusoidal fibrosis on your HVG because I think that we'll pick that up, right? So that's why I showed them that way around. But I think the one is a consequence of another. I think you get the plate atrophy and then you get the perisinusoidal fibrosis, and with time you're going to get more progressive fibrosis in that scenario as well. But they kind of parallel lesions, atrophy first, then the perisinusoidal fibrosis. But absolutely right, the HVG stains collagen. That's different from the reticulin. Yeah.
Thank you. Next question is, can reticulin be lost in adenomas too? To what extent, and how would you differentiate it from well-differentiated HCC?
Yeah, really, really difficult. I think, genuine and reasonably extensive loss of reticulin in an adenoma, no, you shouldn't see that, or you're going to be, if you are seeing that, you have to be extremely guarded about how definitive you are about an adenoma diagnosis. And again, the reticulin is very useful, but it can be difficult to interpret in isolation, especially if you've got an adenoma that's got fat in it. It becomes very difficult. So you have to go back to thinking about the case in its entirety. Go back to the morphology. Is there anything else about the architecture that's worrying you? Are there lots of pseudoacinar structures? Are you seeing the pseudoportal tracts that you expect to see, the unaccompanied arteries? And can you use any other stains or modalities to help you make that differential diagnosis? So it can be really difficult, but adenomas you shouldn't be seeing a lot of reticulin loss. And if you are, then be questioning how certain your diagnosis of adenoma is.
Yeah, Thank you. So the next question is, they're asking about liver special stains panel. Do you do it with all liver core biopsies? Unless for metastatic disease, I noticed that there was no mention for the inflammatory hepatic adenoma. So this is about special stains.
Okay, so I think that's a good question, and I think we, in common with other labs, will treat a biopsy from a mass-forming lesion differently than we will a biopsy for medical liver disease. So if it's for medical liver disease, it gets a full set of special stains straight off. If it's a mass-forming lesion, we just get 2 levels and 10 spares, because you need to make a judgment. If it's a small biopsy, you might want to do additional immunohistochemistry on it. So we do not routinely do a full set of special stains. No, just be selective about your special stains and make a judgment. Sometimes a biopsy comes as a mass forming lesion and it's all background liver, and then I'll do a set of special stains, because at least we can say something about the status of the patient's background liver, but they've missed the lesion, but not routinely, no. So don't do the liver panel on everything. I would say be selective about what you do it on, so that you're making the most of your tissue.
Thank you very much, Rachel. I think we're just about time, and we answered as many questions as we could. Thank you very much, and thank you everyone for attending. We hope we enjoyed today's webinar, and we hope we will see you in our next session. Thank you very much. Bye.